So, good evening, everyone. I am Dr. SJK. I am going to discuss uh, November INI-CET ENT recap questions with you all. So considering the overall pattern of the questions, the ENT was a little bit on the easier side. So, back to the original things, like last 2 years, the trend was from the nose. More number of questions were being asked from nose for the last 2 years, INI-CET, but this time they have gone back to the older trend of asking more number of questions from year. Okay, so this year I had more number of questions from year otology. Okay, so our discussion is going to be like this. So we are going to have a little bit of discussion about the question, and also a screenshot from our workbook that shows that our workbook has 100% strike rate considering ENT, and also screenshot from the question bank that we have exclusively prepared by ADR team. So that you will have some legitimacy about our content. Okay. So first question is, what is the interpretation of the following PTA conducted on a patient? So the PTA picture was something like this. So this was the PTA picture which was given in the exam. So now to answer this particular question, you need to have a clear understanding about a Newton audiogram. This is a screenshot from our workbook which was taken. Okay. So first, how to plot a audiogram. So I've told you always 3 thumb rules for plotting an audiogram. The first thumb rule is, first you should identify whether any curve is more than 25 decibel. Any curve, be it bone conduction or air conduction, any curve more than 25 decibel, you can confirm it as hearing loss present. Second one is, if the bone conduction curve is more than 25 decibel, it confirms that there is sensory neural hearing loss. This is the second thumb rule. The third thumb rule is air bone gap. If the air bone gap is more than 10 decibel, it is conductive loss. Less than 10 decibel is sensory neural loss. So when we apply these 3 thumb rules for this particular picture which was given in the exam, so see here, so this is the 25 decibel curve. So every curve is more than this. Every curve is more than this. So here, first thumb rule is any curve more than 25 decibel, hearing loss is present. That satisfies the first thumb rule. The second thumb rule is the bone conduction curve is more than 25 decibel. It shows that sensory neural loss is there. Okay. The third thumb rule is air bone gap more than 10 decibel, conductive loss is seen. So this is a clear-cut picture of both sensory hearing loss on the second thumb rule and conductive hearing loss based on third thumb rule, which means presented with mixed hearing loss. Okay, so this was a mixed hearing loss picture. So how can be a conductive hearing loss picture and sensory hearing loss picture? So this is a picture of right-sided conductive hearing loss. Okay, this picture of right-sided conductive hearing loss. So this is a picture. So this broken lines are bone conduction. These lines are air conduction, which means the air gap is less than 10 decibel. The bone conduction curve is more than 25 decibel range. This is a right-sided sensory neural hearing loss picture. So this is how you should approach any audiogram picture. So the audiogram picture was extensively discussed in all the previous revision classes. Okay, so this is a screenshot of the question based on mixed hearing loss present in the question bank. Okay, next question. So something similar to the hearing loss classification. So out of these pictures, which is having maximum hearing loss? So see here, serous otitis media will be having hearing loss around 30 decibel. So stapes foot plate fixation again will be around 30 to 40 decibel. So ocular discontinuity with intact TM. So there is ocular discontinuity with intact TM will be around 60 decibel loss. This was written down in some workbooks. Okay. So ocular discontinuity with perforated TM will be around 54 decibel loss. Okay. So this is the continuation of the hearing loss discussion chapter. So this was asked in this exam. Okay. The next question is based from the topic. So mention the surgery shown below. We have one picture showing stapes suprastructure, another picture showing the stapes piston, which is placed over the stapes foot plate. Okay, so what? Very easy to answer. It is stapedectomy, or some say that whatever it is, that should be the answer. Stapedectomy. Okay. So now let's get into the discussion. This is a screenshot from our workbook. So what about the features of the otosclerosis? Otosclerosis will be having bilateral conductive hearing loss. If it is a stapedial otosclerosis, bilateral conductive hearing loss, more common seen in females around reproductive age group, around 30 to 40 years. So the patient will be having autosomal dominant inheritance. So if we do histopathology, there will be blue mantle sign of Manasseh. So blue mantle sign of Manasseh. Then on taking an audiogram, okay, so there will be dip at 2000 hertz. That is called Kerasnach, which was a previous year question. Impedance audiometry shows AS type of curve, which was again an important question. Medical treatment, sodium fluoride. Surgical treatment, comparatively stapedectomy is better than stapedectomy. Stapedectomy is better than stapedectomy. Okay, fine. So a screenshot from our question bank which shows stapedectomy as the correct answer for surgical procedure for otosclerosis. So that shows we are much coherent with the questions has been asked. So most common test used in screening of neonatal hearing loss. Okay, so cakewalk question comparing to BERA, OAE is the best screening test of choice. So let's get back to the discussion. These three are the objective tests done for hearing. So subjective test, we have to rely on the response from the patient. Whereas objective test, we don't have to rely on the response from the patient. We will have some electrical recording of all the parameters that we are going through. So OAE, BERA, impedance are very important, out of which BERA is gold standard for diagnosing many sensory neural hearing loss. OAE is screening test. So what is the principle behind OAE? So naturally, outer hair cells emit energy. Okay, the energy entered by outer hair cells can be captured. Okay, so natural capturing of energy released from outer hair cells is called spontaneous OAE. but the spontaneous OA is not present in all the individuals. It may be absent in up to 30 to 50% of the persons. So how can we use OA for such babies? So in such babies, we could use evoked OAE. So we will give sound of particular frequency. It is called transient evoke. If we use two different frequency and compare the two different frequency for better results, that is called distortion product OAE. Distortion product OAE. Okay. So how can you infer? So this test has good sensitivity. So if it shows normal, hearing is normal. Okay. If it shows rougher, that will be the inference from this OAE. It shows that suspicious of congenital deafness. Suspicious of congenital deafness. So what can you do for these patients? Suspicious of congenital deafness means you should do BERA in these patients. So they are used for screening test, screening neonates. This can be also used for diagnosing noise-induced hearing loss. They can also be used for auditory spectrum disorders. Auditory spectrum disorders. Okay, fine. These are all true responses. Okay, fine. So spontaneous OA absent in 50%. So absent retrograde deafness, absent hearing loss less than. So these are some special points, some add-on points concerning OAE that you can't see in most of the books that we have given in our workbook. So it is absent in retrograde deafness because, so it is not completely absent early stages. It will be weakly positive. The nerve will not be responsive for the patient. So absence in retrograde deafness is some very important, some confusing point that you need to understand. So if the hearing loss is less than 30 decibel, it will be absent. That is also an again confusing point that you need to understand. Okay. So OAE is a very important topic. They're asking repeated questions from OAE, BERA, and impedance audiometry. This we have discussed in our last minute revision. Okay. Then, so which of the following statements are not true regarding a tumor shown in the image below? So this is the image that was given. Okay. This was the image that was given. Similar question was asked some 4 years back in AIMS exam. Same image. The answer for this is vestibular schwannoma in that AIMS exam. So the same image was asked. So now, what are the false statement regarding this particular disease? So the disease is about vestibular schwannoma. Vertical bodies are seen. Yes, vertical bodies are seen. Associated with neurofibromas. Yes. Artificial cranial nerve. Yes. So this is not. So this vestibular schwannoma. Let's discuss about vestibular schwannoma. So this vestibular schwannoma is a benign inner ear tumor. Okay. So it arises from vestibular division of vestibulocochlear nerve. Vestibular division of eighth nerve. Okay. Vestibular division of eighth nerve. So it will cause compression of adjacent nerves. Okay, very important points. So if it causes compression of cochlear division of eighth nerve, it will have tinnitus and progressive sensory neural hearing loss. Progressive unilateral sensory neural hearing loss. Then if it affects the trigeminal nerve, which is present at Meckel's cave, It will cause loss of corneal reflex. Loss of corneal reflex. Okay, fine. If it affects the facial nerve, it is called Hitzelberger sign. Loss of sensation over posterior superior canal. Hitzelberger sign. Finally, it will cause vertigo also, which is not a acute vertigo, it's a chronic vertigo. So it will cause vertigo as it involves the vestibular nerve. So arising from the periphery of the vestibular division of eighth nerve, Schwann cells, it is called as schwannoma. Okay. Now, to put things into perspective, so if we take biopsy from this, no, we can't take biopsy because it is an inner ear tumor. So when we send this for this one, when we send this for biopsy, so it will have this antennae B pattern. Okay. Antennae A, antennae B pattern. So, and also you will see Verroque bodies. So if it is closely or densely packed, it is antennae A pattern. If it is loosely packed, it is antennae B pattern. Okay, fine. So the treatment is surgical treatment can be done by suboccipital craniotomy, translabyrinthine approach, middle fossa craniotomy. Okay. Next approach is retrosigmoid approach. So surgical treatment can be done if the tumor is more than 2.5 centimeter. If the tumor is 1.5 to 2.5 centimeter, you should try stereotactic radiotherapy. Okay, stereotactic radiotherapy. Okay, fine. That's all about. So this is a screenshot from our question bank which shows vestibular schwannoma as an answer with features, histopathological features given. So which fracture is shown in the diagram given below? So the diagram which was given was, okay, this was the diagram. So yeah, vertical fracture line over the nasal septum. This was the diagram. Okay, so the diagram shows vertical fracture line over nasal septum. So which we have discussed adequately. There are two types of nasal septal fractures: Chevrolet fracture, Georgiev fracture. So if the blow is from below, it is Chevrolet fracture. Blow is from front, it is Georgiev fracture. So see here the fracture will be vertical. Here the fracture line will be horizontal. Okay. So you just remember with a mnemonic, front jaw. Okay. Front jaw is the name. Okay, forget this. So front, there will be horizontal fracture line. If it's from the below, there will be vertical fracture line. Okay. The screenshot from our workbook, screenshot from our question bank, which shows chest fracture, which is having difficulty breathing through the nose, longitudinal fracture line over the nasal septum. Okay, fine. Next question: structure behind inferior meatus. So it is eustachian tube, sphenopalatine, spinatus. The structure behind inferior meatus is eustachian tube, approximately 1.5 centimeter behind eustachian tube. 1.5 centimeter behind the eustachian tube. Okay, so see here, this we have discussed elaborately in anatomy of nasopharynx. So behind the nasal cavity will be having nasopharynx. That nasopharynx will be having structures which has relation over the lateral relationship of eustachian tube, torus tubaris, fossa flosum. That eustachian tube opening is 1.5 centimeter behind the posterior end of the inferior turbinate. So to put things into perspective, so what about this sphenopalatine foramen? The sphenopalatine foramen is behind the posterior end of middle turbinate. Posterior end of middle turbinate. Okay. So that's about the inferior meat. Okay. Structure behind inferior turbinate. Fine. So we also can learn about the osteometal complex, which is an opening for middle meatus. So the middle meatus is an opening for the sinuses of maxillary sinus, frontal sinus, anterior ethmoidal sinus. Okay. The posterior osteometal complex, it will be a drainage pathway from posterior ethmoidal sinus through superior meatus. Through superior meatus. If they ask you, posterior ethmoidal sinus drains into, the first best answer is superior meatus. The second best answer can be posterior osteometal complex. Both are one other the same. Okay. Inferior meatus will be having drainage from nasolacrimal duct. Nasolacrimal duct. Okay, fine. So what about the other structures present in the middle meatus? Hiatus semilunaris is a semilunar shaped space below ethmoidal bulla. Okay, so infundibulum is present between uncinate bone and lateral wall of nasal cavity. Ethmoidal bulla is the most constant anterior ethmoidal air cell. Okay, fine. So this is a infundibulum lies between lateral wall and uncinate process of ethmoid. Okay, fine. Next question. So croup is an easy question. Croup is caused by, so croup is acute laryngotracheobronchitis okay. So it is caused by para-influenza virus. Okay, para-influenza virus. Okay, so there are two types of para-influenza virus A, para-influenza virus B. So both can cause this disease. A screenshot from a workbook, see here. So croup is a subacute infection caused by para-influenza virus. Radiological sign is steeple sign due to subglottic accumulation of mucus. Okay, fine. So acute infection in unimmunized individuals causing H influenza or pneumococcus can cause acute epiglottitis. Here the radiological sign will be thumb sign. Radiological sign is thumb sign. Okay. So here clinical sign will be, see here, this is acute epiglottitis where the epiglottis is fully inflamed. As the epiglottis is fully inflamed, the child will find it difficult to breathe through the oropharynx. So if the child acquires a position like this, keeping the hands like this and legs like this, it looks like a tripod. So the child acquires a tripod position to open up the epiglottis, which is highly inflamed in acute epiglottitis, that is called tripod sign, which is a clinical sign. See, thumb signs in a lateral X-ray is a radiological sign. So this is acute epiglottitis. It's a very acute infection. Whereas the question which was asked from croup is a subacute infection caused by parainfluenza virus A and B. Clear? Yes. Last question. So this is a screenshot from our question bank. Okay. Among the nerve injuries which has bad prognosis: bilateral internal laryngeal nerve injury, unilateral internal laryngeal nerve injury, bilateral recurrent laryngeal nerve injury, unilateral recurrent laryngeal nerve injury. Okay. So what is internal laryngeal nerve? Is internal laryngeal recurrent laryngeal nerve. Okay. Recurrent laryngeal nerve. So this internal laryngeal nerve is for sensation above the level of vocal cords. Okay. Whereas external branch is for motor supply to the cricothyroid muscle. So that is the abbreviation for ILN. Okay. So RLN is recurrent laryngeal nerve palsy. So bilateral laryngeal nerve palsy is most severe problem. Both vocal cords will be in param position. So there is no space for breathing. That results in stridor. So that is the reason for bad prognosis, because the patient can go for stridor, acute respiratory distress. The patient can end up, okay. So we immediately need to do emergency tracheostomy. Emergency tracheostomy. All right. Fine. The screenshot from our workbook. So unilateral respiration will be normal. Bilateral there will be stridor. Speech will be, both will be having little bit of hoarseness, which is more on bilateral. Position unilateral paramedian. Here bilateral paramedian. So this is the screenshot from our workbook. Okay. So this is a screenshot from our question bank. So this is, the answer is stridor, which is a worse prognosis compared to other nerve palsies. Okay. So that's all from the questions. So a lot of questions being asked from ENT. Almost all the questions are easy this time comparing to other INI-CET exams. So out of 9 questions, so 8 questions were present directly in our question bank, directly in our workbook. One question which was asked from this articular discontinuity, which was actually discussed in our workbook. So question bank, not the direct question is there. So almost 8 out of 9 questions we are completely having in our material. Okay. I hope you all done your exam in a great way. So keep looking forward for more sessions like this. Thank you.